In the last lecture, we covered telencephalic structures, but we just got through cortical structures and white matter pathways. So we're going to cover these other three areas and really get through the rest of the nervous system in this lecture. So the basal ganglia are deeply located neurons. So not all of the neurons in the brain are out around the surface, the cortical neurons that we talked about. And so as a big picture, what does the basal ganglia do? It selects wanted patterns of movement and suppresses unwanted patterns of movement. So therefore, when we talk about lesions of the basal ganglia, this results in movement disorders. And we have 3 hours on the basal ganglia and movement disorders, and we'll go through all of that in a lot of detail, but you do need to know the structures and the anatomy to understand what's going on clinically with those patients. And so let's come back here to the internal capsule. This is such a helpful landmark here to first be able to identify the anterior limb, genu, and posterior limb of the internal capsule. And we find 2 of the telencephalic components of the basal ganglia near the internal capsule. First of all, we have the caudate right here, which is medial to the anterior limb. Okay, we haven't talked about the lateral ventricles yet, but remember the lateral ventricles you associate with telencephalic structures. And one clue that you're looking at the caudate is the caudate always bulges into the lateral ventricle. So that's just a helpful relationship there. Now, lateral to the entire internal capsule, we have out here the putamen. So when we're doing our horizontal sections, and we start at the top and we work down, we will first come to the putamen, and then as we get lower, we'll see another structure called the Globus Pallidus arise in this very medial portion right here. All right, so again, we've cut further down. Here is the caudate and the putamen, and can you see there's like a little striation, a separation here, and so the nuclei here look a little different, and this is the Globus Pallidus. So this is the other telencephalic component of the basal ganglia. Now, anatomically, the putamen and the Globus Pallidus have kind of a lens shape, and so these are called the lentiform nuclei. This really doesn't have any functional or clinical significance at all. It just is kind of an anatomic appearance. What is more important, though, is that you can lump together functionally the putamen and the caudate. These work together, and these are called the striatum. Okay, so as a big picture, when the motor cortex, which is involved in movement, wants to talk to the basal ganglia to help coordinate movement properly, it talks to the striatum, the putamen and the caudate. So this is the input nucleus of the basal ganglia. So the basal ganglia has all of this circuitry, which we will go over, but when the basal ganglia talks back to the motor cortex, it does so through the Globus Pallidus. Now there's a lot of nuance and more details, but that's kind of the bird's eye view of things. So here's another nice dissection here of the caudate, the putamen. Here we can see a little separation, and here's the Globus Pallidus. And the Globus Pallidus, we will learn later, actually has an internal and an external part. We can see a little difference there. Now this is a coronal section, which means we've kind of cut through, in this case, the front part of the brain. And so we're looking at the caudate, and in this section we can see these kind of striational connections between the caudate and the putamen. That's why it's called the striatum. Now, one thing that can be confusing about a lot of brain structures is that they have a C-shaped. The brain itself is a C-shaped structure, and another C-shaped structure is the caudate nucleus, which wraps around like this. So it has a head, a body, and a tail. And the reason that's confusing is whether we're doing horizontal cuts like this or coronal cuts like this, it means we're going to see the caudate in 2 different places. Okay, so just recognize you're cutting through a C, and that's why you're going to see it in different locations. So in blue, here we have the putamen, and deeper in this area right here is the Globus Pallidus. So the basal ganglia, I told you, have to do with movement, and that is certainly true. But yet, interesting things are discovered as technology gets better, and something called a functional MRI, when we can actually see what is going on in the brain, even in real time. And so this is a famous actress, and she is one of a handful of individuals who have absolute total recall. She can tell you what she did on every day of her life in an encyclopedic kind of fashion. And what is interesting is when special MRI scans are done of these individuals, they have a very large caudate nucleus. And so I don't think this was anticipated, but it is kind of an interesting finding. So obviously these areas of the brain, we don't want to oversimplify their function. All right, so I already mentioned the important landmark of the internal capsule as it relates to the basal ganglia. So again, here's the anterior limb. Medial, we have the caudate. Lateral, we have the lentiform nuclei, okay, which really are lateral to the entire internal capsule here. And again, the globus pallidus, when the basal ganglia does all of its processing, it talks back to the motor cortex. Okay, here we can see better a separation between the putamen and the globus pallidus. So this really is practical. When we talk later about deep brain stimulation for Parkinson's disease, if you don't know the anatomy of all of this, then certainly if you're in that area of neurology or neurosurgery, it's just not going to work. So it's important knowledge. Now, the non-telencephalic components of the basal ganglia are the substantia nigra and the subthalamic nucleus. The substantia nigra is in the midbrain, and so remember the midbrain is of mesencephalic origin. So the substantia nigra comes from the mesencephalon. And we'll spend a long time talking about the substantia nigra. Dopamine is produced in the substantia nigra. Degeneration of the substantia nigra results in Parkinson's disease. And it always has a distinctive appearance because of the neuromelanin. It makes the neurons stain darkly. So even when we do our gross sections with the naked eye, you can see the substantia nigra. The subthalamic nucleus has the name thalamus in it, so it's of diencephalic origin. And we get a very interesting movement disorder with a lesion here, where if we have an acute lesion, let's say on the right subthalamic nucleus, patients will develop these dramatic, wild, flinging movements on the opposite side of the body. So that is called Hemi Bolismus. Hemi is one side, and Bolismus is like a ballistic kind of a movement. Okay, so again, in another section here, this is a coronal section, and we see the caudate. This is cut through the posterior limb of the internal capsule here. Okay, so lateral to that, we see the putamen, the globus pallidus, and the substantia nigra. Again, the dark staining cells here, that's always the giveaway. And so once you've found the substantia nigra, you know this has to be the midbrain. Okay, and the subthalamic nucleus is a football-shaped nucleus here and here, which is just kind of above and lateral to the substantia nigra. Okay, and we'll also appreciate in the lab its close relationship to the posterior limb of the internal capsule right here. Okay, and sometimes helpful just to look at it without the labels. Okay, so again, kind of fix in your mind what the subthalamic nucleus looks like. Here's maybe a better example. It looks like a football. Okay, the limbic system I will go through very quickly. We have 2 hours on the limbic system from Dr. Perot on Thursday. So what is the limbic system? It consists of cortical and subcortical prosencephalic structures on the medial aspect of the hemispheres. So let's unpackage that sentence just a little bit here. So what is prosencephalic? So remember, the prosencephalon is just equivalent with the cerebrum of the brain. And so the limbic system will consist of prosencephalic structures. So some will be telencephalic, some will be diencephalic, and we find them in the more medial aspect of the brain. So way to remember function of the limbic system is home. First is homeostatic function, And so the hypothalamus is part of the limbic system. Hypothalamic pituitary axis controls the autonomic system and also neuroendocrine function. So this is a function of the limbic system. Olfaction, we will see, is part of the limbic system. Memory, in an area in the limbic system called the hippocampus especially, is very important, especially for laying down new memories. Okay, and then a lot of the limbic system, we'll mention the amygdala and other areas, are critical for the unique way each of us respond to emotional stimuli. So here are the parts of the limbic system I'd like you to know for now. Two of them we've already talked about, the parahippocampal gyrus and the cingulate gyrus. So now we need to incorporate these other structures. All right, so first let's just point out the parahippocampal gyrus right here. I mentioned it's just lateral to the uncus. Okay, so this is part of the limbic system. Now if we want to see the amygdala and the hippocampus, we actually need to do a cut into the temporal lobe. Okay, and so the amygdala is in the anterior portion of the temporal lobe. So if we do a cut like this, right through the uncus, deep in here, we will find the amygdala, and as we cut further back through the temporal lobe, the amygdala will disappear, it's right about here, and then we will see the hippocampus as we work back. All right, so here is a cut where we cut off the tip of the temporal lobe over here, and there's where we find the amygdala, and then behind the amygdala lies the hippocampus. All right, so it's another kind of a C-shaped structure here, the amygdala, and then the hippocampus, and we'll talk about this connecting pathway here to the hippocampus in just a minute. So here is a cut we will do in the lab. We'll cut half the brain like this, and notice we're cutting off the tip of the temporal lobe over here, and that's exactly where we look to find the amygdala. And so the amygdala in Greek means almond, and it really does look like just the shape of an almond. It's a homogeneous mass of neurons in the anterior portion of the temporal lobe. Okay, so as we make one cut further back, we go from a homogeneous mass to now something that looks sort of like a cinnamon roll rolling up, and that is the hippocampus. It has a very different kind of appearance than the amygdala. All right? Notice there's a space in dark here around the hippocampus, and so this is, on Thursday, you'll see this is the temporal horn of the lateral ventricle that goes down into the temporal lobe. So it's kind of a helpful clue. We find the hippocampus embedded right in that. So other parts of the limbic system, we've already talked about the cingulate gyrus. All right, Dr. Perot will tell you that the cingulate gyrus is important for emotions, including having empathy. And maybe this is just a time to mention, because I mentioned the frontal poles. If you have a lesion here, you have a patient with a loss of empathy. And so the point here that's worthwhile making is that with a lot of functions of the brain, with some exceptions, like the language areas are just in discrete areas, the motor cortex is in a very discrete area, but many other functions of the brain, we don't want to just say it's in one area only. Okay, these are complex networks in the brain, and so empathy can actually localize to 3 different places in the brain, or a problem with empathy. Another one is the cingulate gyrus. Also, I told, I think the class yesterday, that the phrase, I love you with all my heart, of course it really isn't the heart that is doing that. It has to be somewhere in the brain, and the cingulate gyrus is the best candidate for that. So we can speak in an anatomically correct manner and maybe say, I love you with all my cingulate gyrus. Now, the hypothalamus has thalamus in it, so it's part of the diencephalon. So here is the whole diencephalic structures are located kind of back in this area, and this more ventral portion right here is the hypothalamus. Let's say a bit more about the hippocampus. The hippocampal formation is often used interchangeably with the hippocampus, but there's, when we say the hippocampal formation, we're really implying all of these different areas that are part of this. And so there's a dentate gyrus, and then the hippocampus proper here is CA1, CA2, CA3, CA4, and then we have the subiculum. Okay, so that little curlicue thing I showed you is made up of discrete areas. The only one I really want you to remember is CA1, because this has a classic neurologic syndrome that we're going to talk about later. So I won't ask you about the others, but I would like you to know CA1 as an important area. Now, things that go in and out of the hippocampus, so again, here we have the dentate, the CA1, and so on, the subiculum. The entorhinal cortex is kind of think of the gateway of what gets in and out of the hippocampus. So the hippocampus is very important for the formation of short-term memory and the process of making long-term memories. Okay, and we have an hour lecture on memory, and we'll kind of go through the details of how that works. For now, I just want to cover a little bit of the neuroanatomy of that. So if we have a problem with the hippocampus, and the classic condition that would be associated with this is Alzheimer's disease, where the hippocampus atrophies quite early in that condition, there's a memory problem, but it's mainly short-term memory. So long-term memories get laid down in other areas of your cerebral cortex, which we'll discuss later. But if you don't have a functional hippocampus, you're not laying down new memories. And so these patients with Alzheimer's can tell you in a lot of detail what happened 40 years ago, 50 years ago, but they can't tell you what happened yesterday because they're not laying down new memories. The other distinct function of the hippocampus is it really is like an internal GPS system for sense of direction. And so degeneration of the hippocampus leads to spatial disorientation. And a common symptom that we see early on in Alzheimer's disease is patients get lost driving, and in more advanced cases, patients can get lost in their own home. Here was a Norwegian scientist years ago who won the Nobel Prize for really, mapping out what's going on in the hippocampus as an internal GPS tracking system. And they've done these functional MRI scans in people like taxi drivers in London. If you've ever been in London, the streets there are enormously complex. It's a huge city. And so anyone that's been a taxi driver in London for a long time, they actually have a really large hippocampus because they're really developing that part of their brain in terms of spatial orientation. All right, so a circuit that is involved in laying down new memories is called Papes Circuit. A medical student years ago called this the Papes Racing Circuit. And so it starts down here in the hippocampus. Okay, and there's a pathway from the hippocampus that goes like this, another C-shaped structure, down to the mammillary bodies. Mammillary bodies, we will see, are part of the hypothalamus. Okay, from here, this goes up to the anterior nucleus of the thalamus, and then to the cingulate gyrus right here, and then back down to the hippocampus. So that is the circuit. Okay, and let's look at another cartoon drawing of this. Okay, so here's the amygdala, the hippocampus. Remember, the entorhinal cortex is kind of the gateway to the hippocampus. So, and I probably should say the hippocampal formation to be more accurate. All right, so from the hippocampus, we have here the fornix, which goes down to the mammillary bodies, then up to the anterior nucleus of the thalamus, and then up to the cingulate, and then back down to the hippocampus. So that is Papes Circuit, and it does have an important role in laying down new memories. And I'm sorry, this isn't the best quality picture, but things are just kind of difficult to get the 3D relationships early on in neuroscience. So the hippocampus is out here in the temporal lobe. All right, the mammillary bodies are right next to each other in the midline. I'll show you a picture in just a minute. So the columns of the fornix kind of move a little bit from lateral to medial as they dive down here to the mammillary bodies. All right, the amygdala we can think of as the alarm switch in the brain. So that initial jolt, shock of electricity and tachycardia that you get with a loud noise or something like that, that is the amygdala that fires. So it's externally focused and it responds to the environment. Okay, and Dr. Perot will go into this in a lot more detail. There is a syndrome if we have a destructive lesion, especially of both temporal lobes. And so that can happen like with head trauma, where we get kind of a shearing effect on both temporal lobes. And this is known as Clover-Bucy syndrome. And so if we destroy the amygdala bilaterally, there's impaired threat assessment. Okay, so that's one part of the Clover-Bucy syndrome. You'll learn more about that later. So the hippocampus talks to the hypothalamus. The amygdala also talks to the hypothalamus. Remember, the hippocampus talks to the hypothalamus, the mammillary bodies, via the columns of the fornix. The hypothalamus talks to the amygdala via the stria terminalis. Okay? Another clinical application of the amygdala, if the amygdala fires inappropriately, meaning there's nothing happening, there's no threat, but it still is overactive. We see that in a condition called PTSD, post-traumatic stress disorder. And so, someone has had a war experience or other trauma in their life, and over time, they can have a too easy firing of the amygdala, and this is actually quite harmful to the brain. It needs to be treated. All right, so here is the amygdala. All right, we kind of find it right at the end of the caudate nucleus here, the C-shaped structure. And so in purple, we see the connection from the amygdala to the hypothalamus. So this is the stria terminalis going down to the hypothalamus. It's a really small pathway, but we'll try to see it in the dissection lab. Now, another part of the limbic system is the Nucleus Accumbens. And so here's the caudate nucleus in green. The Nucleus Accumbens is just anterior to the head of the caudate. So it's about in this location. Okay? And so if we were to do a coronal cut like this, a very anterior cut through the brain, this is where we would look for the Nucleus Accumbens. And so in this section here, we see the caudate and the putamen, and it's right in this location, okay, in an anterior location of the brain, kind of at this junction between the caudate and the putamen. So what does the Nucleus Accumbens do? It gets projections from both the amygdala and the hippocampus, and it also gets important dopamine projections from an area in the midbrain that we haven't talked about yet called the ventral tegmental area. You know the expression, someone will ask, how do you get your dopamine? Sort of, how do you get your reward in life? And so kind of associate the Nucleus Accumbens with that. It's associated with reward, motivation systems. There are interesting studies of people listening to the music that really resonates with them, music they really enjoy. And the Nucleus Accumbens is very active in that experience. All right, so this is all a healthy, good thing, but abnormal activation of the Nucleus Accumbens we will see in drug addiction, and also in Parkinson's disease, where the brain is not making enough dopamine. So we give patients dopamine medications. Well, that helps them with their Parkinson's disease, but one common side effect of these medications is that the dopamine medications you give can overly stimulate the Nucleus Accumbens, and that can result in what's known as impulse control disorder. We deal with this a lot in neurology in our Parkinson's patients. So the patient may have a drive to play video games, something they've not really done before, but now they're just obsessed with it. Or can have even a new addiction to things that are online gambling, sometimes pornography. And so we always ask about that in our Parkinson's patients that we're giving dopamine medications to. Usually better to ask the spouse if they're seeing anything like that. So the cingulate gyrus, I mentioned earlier, the anterior portion is important for energizing. Okay, but remember it's part of Papes Circuit, so it's also important in the process of laying down new memories, and it's also very important for emotional processing. So there's a lot going on here in terms of the function of the cingulate gyrus. Now finally, the olfactory system, which we'll just say a word or two about. So the olfactory bulb and tract, I've already mentioned, and then there are these connections, the olfactory stria, which connect the bulbin tract with the uncus, which remember is primary olfactory cortex. Okay, the amygdala also talks with the uncus. Remember, the amygdala is just deep in this area. So here we have the olfactory bulb and tract going back here to the uncus. And we will talk later in the course in a lot more detail about the thalamus. And I will tell you that anything that wants to communicate with the brain has to go through the thalamus. Sensation in your arms and legs, vision, sound, it all has to go through the thalamus. And for some reason, the sense of smell is one exception to that. So olfaction gets directly to this cortical area without needing to go through the thalamus. Now, why is the uncus have a direct relationship here with the amygdala and also the hippocampus? Some of you may be aware that we're actually quite good, most of us, with tying a smell, maybe even something that you haven't experienced in a long time, with a distinct memory. Not too long ago, I walked through my old high school, when I graduated there in 1984, and a smell in a certain hallway was exactly, I could have been blindfolded and I would have known exactly where I was. So the memory and the emotional areas here are intimately connected here with a sense of smell. A meal that you really enjoy can evoke all kinds of emotions and memories and so on. Here's just a drawing showing you these olfactory stria that go back here to the uncus. We won't be able to see those in our lab together. Now, I've mentioned some directional terms, but I wanted to just go over this again because this can be confusing. Because I will be showing you horizontal sections through the brain. So this is a horizontal section. A coronal section is like this. And usually we just do one sagittal section through the brain like this. It's important to recognize this also when you're looking at head CTs or MRIs, because the MRI will tell you this is a horizontal, a coronal, or a sagittal section, and so you just need to be properly oriented. The other directional terms that are really important here are the rostral caudal axis of the brain. So again, because the brain is a C-shaped structure, it curves forward. This is our rostral caudal axis. Now the spinal cord is easy. We have things that are ventral or anterior. This is synonymous in the spinal cord. And then we have things that are dorsal or posterior to the spinal cord. But as the rostral caudal axis curves forward, then the ventral dorsal aspect curves as well. So here's ventral, here's dorsal. And so when I went over the frontal lobe earlier and we talked about the lateral prefrontal cortex, I said there's a dorsolateral and a ventrolateral. And again, it reflects that rostral caudal axis here. When we're up in this part of the brain, this is dorsal and this is ventral. All right, so this then are horizontal cuts through the brain. Coronal cuts would look like this. All right, so we've now been through all of the telencephalic structures. The rest of this will go much faster here. Let's talk about the diencephalon. So the diencephalon is just above the midbrain, rostral to the midbrain. All right, so here's the midbrain we haven't talked about yet, but the diencephalon is this whole area here, so it is rostral to the midbrain, and it's just below all of the telencephalic structures. Okay, remember the internal capsule is a very helpful landmark here for a lot of things, and so the thalamus is medial to the posterior limb of the internal capsule. So find the internal capsule, and medial to the posterior limb is the thalamus. And remember that the ventricular system that is associated with the thalamic structures is the third ventricle. So this space right here is the third ventricle. All right, so the epithalamus is the least important part of the diencephalon, and I'm just going to have you for now know about the pineal gland as one part of the epithalamus. So I'll point out the important location. It's just above the dorsum of the midbrain, And the pineal gland secretes melatonin. In our sleep lecture, we will talk more about melatonin. All right, so here again is the midbrain. This is the dorsum of the midbrain. And so right on top of that is the pineal gland. Okay, here is the thalamus, and then here is the hypothalamus. So the pineal gland secretes melatonin and a couple of other things. It calcifies in adults, which you would think, why is that important? It really is only important when we're looking at head CTs. And the importance of calcium on a CT is that it makes things look bright. So when we're looking at a head CT and we see this bright spot kind of right in the middle of the brain, you've just identified the pineal gland, and so now you know kind of where you're at. So it's kind of a helpful landmark. In our brainstem lecture, we will talk about Paranods Syndrome, which occurs when there is a tumor of the pineal gland. The habenular nuclei are also part of the epithalamus, but I'm not going to ask you to know about that. So again, here's the pineal gland. Okay, and you can't imagine if you had a pineal tumor, what structures would be involved? Well, here's the midbrain. Okay, so that's the important clinical aspect of Paranods syndrome, and we talk about that later. Now, the thalamus itself is the largest part of the diencephalon. So again, we're going to look for that relationship with the internal capsule. And so it's medial to the posterior limb, and it is lateral to the third ventricle. So the thalamus is really large. There are lots of individual thalamic nuclei for every function: vision, sound, sensation, and so on. The big picture of the thalamus, it's sometimes called the executive secretary. And so think of the thalamus as kind of the area of the brain that decides how much your brain is going to be bombarded by a certain amount of information. So if you're sleeping at nighttime and there's a noise and you think it's coming from inside your apartment, you're alerted. Okay, your amygdala would do that. But then the thalamus is the area that can decide, okay, do we need a lot of information or not so much? Well, at that time, you want every bit of information, right? You want every sound. You want your vision to be, getting everything. And so the thalamus is going to just open the floodgates and let everything in. At other times, like during a lecture, you don't want to be distracted by every little sound that someone else in the classroom is making or what's going on with your foot, things like that. And so at that time, the thalamus will kind of shut everything down and just allow you to kind of focus and be in the zone, so to speak. So on a sagittal section, again, here is the thalamus. Now, about 80% of individuals have a interthalamic adhesion, which I only bring up because everyone keeps asking me about it when we do our brain dissection lab. What is that? And so you can occasionally see this kind of connection between the right and left thalamus. It has zero clinical significance, but you're going to see it, and so now you know what it means. Okay, just another nice picture here of the thalamus. MRI scans are so incredibly accurate. This is actually about a 10, 12-year-old MRI, so things have only improved, but here we see the anterior limb, the genu, the posterior limb, caudate, putamen, and then here is the thalamus. Now, the hypothalamus is ventral to the thalamus, so think about what that means. Here's our rostral caudal axis, and so this is ventral, this is dorsal. So this is the hypothalamus, this whole area right here. And when you identify the hypothalamus in lab, I want you to look for three things that are around the hypothalamus. First, here's the hypothalamus. So on the floor of the hypothalamus, we have the mammillary bodies right here. Mammillary bodies are part of the hypothalamus. So remember, this is the first step in Papes Circuit. So the hippocampus is communicating with the mammillary bodies. Also, we have an important part of our visual pathway here known as the optic chiasm, which I haven't told you about yet. So this is also kind of on the floor of the hypothalamus. Okay, and this pathway right here is the anterior commissure. Remember, this is the pathway that interconnects the hippocampus, temporal lobe structures on either side. And actually, there is a fourth area, which I will tell you about on Thursday, this is called the interventricular foramen of Monro. CSF gets from the lateral ventricles, which are kind of up here, and into the third ventricle, which is right here, through this interventricular foramen of Monro. But that's on Thursday. So like the thalamus, the hypothalamus also has lots of individual nuclei that have a unique function, and we have an hour lecture to go over all of those. Okay, so for now, as again a big picture, the hypothalamus is the head ganglion of the autonomic nervous system. All right, so in terms of sympathetics, parasympathetics, the hypothalamus is, in a sense, in charge of that. And of course, the hypothalamus gets input from the brain, but it's the head ganglion. The hypothalamus controls the pituitary, so our neuroendocrine function here is important. And Dr. Perot will talk about these visceral regulatory areas in the hypothalamus. Important things like controlling satiety when you're full, or body temperature, circadian rhythms, and sleep cycles, all a function of the hypothalamus. All right, in the last part of the diencephalon, we've already talked about the subthalamus. And so functionally, this is part of the basal ganglia, and we've already said that a lesion right here will give a patient Hemi Bolismus, opposite side of the body. All right, the brainstem, we have 3 hours on the brainstem, is a difficult area because it's relatively small and there's just so much packed into the brainstem. So we have these ascending sensory pathways, all the sensation from your arms and legs, descending motor pathways, so how the brain is moving the face, the arm, and the leg. We have important autonomic pathways, massive connections with the cerebellum. We have cranial nerves 3 through 12 that we'll find in and around the brainstem. And then we have an area in the brainstem, millions and millions of neurons that are mainly in the pons and in the lower midbrain, called the Reticular Formation. Think of this as like the light switch for the brain, which is the light bulb. Okay, it's important for activating the brain. And therefore, if we have a lesion involving the Reticular Formation, the patient can be in a coma. It can be a relatively small lesion, but yet you knock out the reticular activating system and the patient may not be able to wake up. So because so much is packed in here, unlike the brain where out in the hemispheres, we do a brain scan and all the time we'll find a small stroke or another lesion and the patient was completely unaware of it, never had any symptoms. That is usually not the case with a brainstem. If we have a lesion in the brainstem, it's going to disrupt some of these important pathways and other structures. So the midbrain, recall, is equivalent with the mesencephalon. So it lies between the diencephalon, which is above, and the pons, which is below. And so we first have these cerebral peduncles, which are in this kind of anterior lateral portion of the brainstem. And this is a continuation of the pathway that we talked about in the posterior limb of the internal capsule, and that is the Corticospinal Tract. All right, so here is our midbrain, okay, but the cerebral peduncles are anterior and kind of lateral. So if you were to actually put your finger in this space right here, you would be touching the cerebral peduncle. All right, so let's see, how can we find the midbrain here? If we look at the undersurface of the brain, here we can see the pons, which is always very distinctive. So the midbrain is deep in here, okay? The cerebral peduncles are kind of lying out in this location. And so to see the cerebral peduncles, and I'll have you do this in the lab, you just need to take the temporal lobe, pry it apart a little bit, and look for the cerebral peduncle deep in there. So if we just pull the temporal lobe apart a little bit, here I've highlighted this in kind of a yellow-green color, here is the cerebral peduncle. Okay, it's a very large pathway. And so this is a continuation of the posterior limb of the internal capsule. There's more than that in there, but that's at least part of what's in the cerebral peduncle. Now we look for a couple cranial nerves around the midbrain. One is the trochlear nerve, which kind of comes from the back of the midbrain. It wraps around like this. Okay? And the other is the third nerve, which we can see over here. Here's the cerebral peduncle on this side. And here's the third nerve coming out here. Unfortunately, the third nerve was lost on this side, but just imagine there's another third nerve here. So the third nerves come out in between the cerebral peduncles. Here's one, and here's one. Third nerve is always really large, always very obvious. So this space right here is called the interpeduncular fossa. It's the space between the peduncles, basically, and that's where we look for the third nerve. Here we can see the mammillary bodies right here. Now, if we cut everything away, here we see the pons, and here are the cerebral peduncles, and again, here are the third nerves coming out in this interpeduncular fossa, and here again we see the mammillary bodies. Now, I showed you this coronal section earlier, and so remember what a coronal section is. And imagine that we've started at the front of the brain, we cut through the anterior limb of the internal capsule, we cut through the genu, and now we're back to the posterior limb of the internal capsule. And so here we've cut right through the posterior limb of the internal capsule. Here's the caudate, putamen, globus pallidus. Here's the thalamus. So we follow the posterior limb, the corticospinal tract, as it travels down. We know that this is the midbrain because we see the substantia nigra. And so the lateral portion of the midbrain right here are the cerebral peduncles. Okay? So again, the subthalamic nucleus has an important relationship, kind of like right where the posterior limb becomes the cerebral peduncle. That's where we look for the subthalamic nucleus. Okay, so we first have the cerebral peduncles, and then as we move back, we come to an area of the brainstem called the tegmentum, which is kind of the middle portion of the midbrain. And for now, I'll just have you know two structures that are in the tegmentum, the red nucleus and the substantia nigra. So this area right here, this middle portion, is the tegmentum. So if we were to do a cut right through that area, we would see the lateral anterior portion, which are the cerebral peduncles. So here's the tegmentum, okay, which consists of the substantia nigra, the dark staining neurons here, and the red nucleus is about in this location here and over here. Okay, later on we'll talk about the function of the red nucleus. Now remember, there's a ventricular portion with every level of the neuroaxis, and so the cerebral aqueduct is right here. Okay, this is the flow of cerebral spinal fluid as it goes through the midbrain, the mesencephalon. So here's a drawing of the midbrain. So here are the cerebral peduncles. Remember, the third nerve comes out in the interpeduncular fossa. Later on, we'll talk about all the complex things that the third nerve does with controlling your eyelid and eye movements, pupil. Okay, here is the substantia nigra, labeled over here. In the red nuclei, here's the cerebral aqueduct. Okay, and now we'll come to the dorsal aspect of the midbrain. And that area is called the tectum, or sometimes called the quadrigeminal plate, because there are four very obvious large bumps on the tectum. And these are called the superior and inferior colliculi. So the tectum is this area back here. Okay, this is the superior colliculus, and this is the inferior colliculus. So now what we've done here is we can do a cut like this to expose this part, this dorsal part of the midbrain. And so there we can see a superior colliculus and an inferior colliculus. Notice also there's something sitting right on top of the superior colliculus, and that is the pineal gland right here. Also, what is just above the superior colliculus? Well, here's the thalamus. And so what we're seeing here is the pineal gland and the thalamus. Okay, what is a midline space that you associate with the thalamus? Well, this has to be the third ventricle. Okay, so the superior colliculus, for now, I'll just tell you this has to do with vision. We'll explain that in more detail later. The inferior colliculus has to do with sound, auditory information, and we'll explain the details of that also later. Now here's one unique thing about this area of the brainstem. You'll notice there's a nerve coming out right here. Okay, this is the trochlear or the fourth nerve, and this is the only cranial nerve that exits the dorsum, the back of the brainstem. Okay, so it's in this distinctive location. It has to wrap all the way around here to come out and supply an important eye muscle called the superior oblique. We'll talk about later. Okay, so again in the tectum here, this drawing shows you the superior colliculus. Now the pons, remember, is part of the metencephalon, and so there is a very large structure. The reason the pons has such a distinctive large appearance is because we have two massive pathways that come together in the pons. So the basis pontus consists of two pathways, the middle cerebellar peduncle and the corticospinal tract. Okay, so you can never miss the pons, right? And if you kind of look very closely, you can see these fibers are running this way. They're going down into the cerebellum. Okay, and so this pathway is called the middle cerebellar peduncle, and it's a very important connection between the pons and the cerebellum. Okay, and the other really important pathway is the corticospinal tract. This pathway we keep talking about here. Remember we said it's in the cerebral peduncle up here. Well, where's the corticospinal tract going? It's going down to the spinal cord. So of course it has to travel through the pons as well. Okay, and so the corticospinal tract and the middle cerebellar peduncle together make the pons, so large and obvious. Now, cranial nerves that we associate with the pons are the trigeminal nerve, which is very large in this kind of lateral portion over here. We'll discuss later, there's a sensory and a motor component to the trigeminal nerve. The sixth nerve, or the abducens, comes out right at this junction between the pons and the medulla. And then we have cranial nerves 7 and 8 coming out in this location here, 7 and 8. Okay, and this is in a location called the cerebellopontine angle, 7 and 8. All right, so here again, I think maybe you can appreciate, these fibers, the middle cerebellar peduncles going down like this. We can see the trigeminal nerve, the abducens nerve, and here are cranial nerves 7 and 8. So one clinical aspect, a tumor likes to grow in the cerebellopontine angle, and this is called an acoustic schwannoma, or sometimes an acoustic vestibuloma. And early on, this tends to compress the eighth nerve. Eighth nerve is involved in hearing, but also in balance. And so early on, patients complain of hearing loss, often a ringing in their ears called tinnitus, and often some dizziness as well. As the tumor expands, it can easily compress the facial nerve. So if you see a patient that has a 7th and an 8th nerve palsy, you want to put the lesion right here. That patient needs a brain scan to see if they have this tumor. Now, if this enlarges over time, it certainly can grow to involve the trigeminal nerve, or it can even compress on the cerebellum, which is right here. Okay, and then the medulla, which remember is equivalent with the myelencephalon, lies between the pons and the spinal cord. And so I keep mentioning the areas here of the nervous system that contain the corticospinal tract. So remember, we've pointed out the corticospinal tract in the posterior limb of the internal capsule, in the cerebral peduncles, and in the basis pontus. And now when we get down to the medulla, we find the corticospinal tract in the medullary pyramids, which is in an anterior or a ventral location. And when we say things like one side of the brain controls the opposite side of the body, well, here is a good example of that, because the corticospinal tract does cross. And the important crossing occurs at the kind of very low portion in the medulla, and that is called the pyramidal decussation. A decussation is a crossing, okay? And so this is called the medullary pyramid, so it's the pyramidal decussation where this pathway crosses. So same cut that I've shown you before, a coronal cut through the posterior limb of the internal capsule. And so we can follow the corticospinal tract here in the posterior limb, in the cerebral peduncle, in the basis pontis. So remember, the basis pontis has the corticospinal tract, and this is actually the middle cerebellar peduncle right here. Okay, and then we follow this down, and now the corticospinal tract is in the medullary pyramid, and then it actually crosses over right here. Okay, and this will travel down, and we'll talk later about how it talks to neurons on the opposite side of the spinal cord. Okay, so again, just a drawing showing you the cerebellar peduncle, corticospinal tract, basis pontis, medullary pyramid. Now, the cranial nerves associated with the medulla are sometimes difficult to identify. The hypoglossal nerve is usually the easiest because it comes out just lateral to the medullary pyramid and just medial to another large bump over here called the inferior olivary nucleus. So if you see any nerve twigs coming out in that location, it has to be the hypoglossal nerve. Cranial nerves 9, 10, and 11 all come out lateral here to the inferior olivary nucleus. And it often just looks like a mass of nerves coming out. So it's sometimes hard to say exactly, is this 9 or is this 10? You'll see in the lab it's often quite difficult. Okay, so the inferior olive is lateral to the medullary pyramids. And when we get to the cerebellum, I will tell you that the inferior olivary nucleus is functionally really part of the cerebellum. Okay, and we look for 9, 10, 11, and 12 in and around the medulla. All right, so here's just another look at the medullary pyramid. Here's the inferior olivary nucleus. We see some nerve twigs coming out here, so this is 12. Okay, here we cut everything away just to show you the medullary pyramid and the inferior olivary nucleus. Okay, so don't forget, medullary pyramid, the basis pontis here, the cerebral peduncles, these are all anterior. So when we're making cuts, we're always going to look for the corticospinal tract in this sort of anterior location. So here we did a cut right through the medulla. All right, and so notice, here's the pons, and these are the medullary pyramids. They're anterior. And then here's the rest of the medulla and the cerebellum. All right, so the cerebellum lies immediately under the occipital lobe. There's a reflection of the dura, very tough reflection of the dura called the cerebellar tentorium, which kind of stabilizes the brain by going between the occipital lobe and the cerebellum. The cerebellum has a midline portion called the vermis, and as we move out laterally, there's an area called the paravermis, and then the largest part of the cerebellum, the more lateral portion, we call the cerebellar hemispheres. Okay? And we divide the cerebellum into 3 lobes, an anterior, a posterior, and a flocculonodular. So in a drawing, here's the anterior lobe. Here's the posterior lobe. Okay, and we have a primary fissure here that kind of separates the anterior lobe from the posterior lobe. The flocculonodular lobe is kind of in the midline right here, so you really can't see it on a sagittal section. All right, so again, an anterior lobe and a posterior lobe. Here's the primary fissure. Now this is a coronal cut. Again, this would be a coronal cut, right? Maybe kind of like in this orientation. And so this shows you the occipital lobe above and the cerebellum below. All right, this is a cut through the pons to show you the very large middle cerebellar peduncle, which connects the pons with the cerebellum. And so actually the cerebellum communicates with both the midbrain, pons, and medulla. So the largest connection is that middle cerebellar peduncle, but there is also a superior and an inferior cerebellar peduncle as well. Okay, so here's the cerebellum, the anterior lobe and the posterior lobe. Okay, the midline portion is called the vermis, and then this would be the lateral hemisphere of the cerebellum. And in blue here we have the flocculonodular lobe. We'll explain the significance of that later, but it's mainly important for coordinating how your eyes move. Now, the equivalent of a gyrus here for the cerebellum is a folia, called a folia. You can see they're much smaller than the gyri in the brain. All right, so let's give you a big picture of the cerebellum. We said it's connected to the brainstem, midbrain, pons, and medulla through the superior, middle, and inferior cerebellar peduncles, respectively. And so this is not entirely correct. There are some exceptions, but I just want to give you a little bit of a foundation, and we can build on from there. The one thing that is absolutely true is that there is only one pathway that goes through the middle cerebellar peduncle. And this is a pathway that's going from the cortex to the cerebellum. So with respect to the cerebellum, this is an afferent pathway. It's going into the cerebellum. So that one's easy to remember. Now, the inferior cerebellar peduncle that's connected to the medulla is mainly afferent. It's mainly information going from the spinal cord to the cerebellum. Okay, we'll see there's a lot more going on here, but for now, just remember that. All right, the superior cerebellar peduncle connects with the midbrain, and this is mainly outgoing information from the cerebellum back to the cortex. So with that in mind, let's give you a big picture of how the cerebellum works. It acts as a comparator. Okay, it compares basically intended movement from the cortex of your brain with actual movement, and it helps the brain to make movement very precise and accurate. And so therefore, if we have a disease or lesion of the cerebellum, we have a very poorly coordinated patient, and that is called ataxia. Okay, and also the cerebellum, remember I mentioned the flocculonodular lobe, helps to coordinate how your eyes move. And so if we have a lesion there, we will get something called nystagmus, which basically describes the eyes, kind of jiggle. They don't move normally. Okay, so here's kind of an overview of how the cerebellum works. Let's assume this is the left side of the brain. Okay, and let's follow the corticospinal tract here in red. Okay, so we've already mentioned the corticospinal tract travels through the posterior limb of the internal capsule, through the cerebral peduncle, through the basis pontis, through the medullary pyramid, and then it crosses. Okay, and it is going to activate neurons in the spinal cord to move muscles on the opposite side of the body. So let's say that I want to do something, I want to pick up a pen with my right hand. So the left motor cortex is going to activate this pathway to move muscles in my right arm and hand so that I can accurately perform that function. Okay, that is the intended movement. Now, when that pathway is activated, it also activates a parallel pathway here. And this pathway is called the cortico-pontocerebellar tract. And the name, it tells you exactly what it does. It goes from the cortex to the pons, so it synapses in these pontine nuclei. And then this is the pathway that makes up the entire middle cerebellar peduncle. So it's going into the cerebellum. And there are a bunch of different cells in the cerebellum, but for now, I'll have you just know one of them. They're called Purkinje cells. So what just happened? Well, a pathway was activated to move my arm and hand, but now the cerebellum knows what the intended movement was. It's informed. Now, to serve as its role as a comparator, it needs to get what is actually happening in these muscles. And so when you move your arm and hand, it activates these receptors, we'll talk about later, that then send nerve impulses up to the cerebellum through the inferior cerebellar peduncle. Okay, and so now the cerebellum knows the intended movement, it knows the actual movement, and through an enormously complex circuit, it can then basically inform the brain through the superior cerebellar peduncle in terms of how accurate was the movement. And in real time, it is continually sending information back up through the superior cerebellar peduncle so that the motor cortex up here can make corrective movements so that movement is always very precise. So therefore, let's just say we have a lesion here of the right half of the cerebellum. So the patient is going to have ataxia. Which side will they have ataxia on? Well, the right cerebellum is helping the left motor cortex move your right arm and hand, and your leg. And so therefore, a right cerebellar lesion will result in ataxia on the same side of the body. So we would call that ipsilateral, same side, ataxia. Now finally, the spinal cord. There's an opening, the base of the skull called the Foramen Magnum. And so the cervical spinal cord is, remember, just below the medulla, and it extends from the Foramen Magnum, very important, to the L1-2 vertebral body level. Very important you remember that's where the spinal cord ends. Okay, so we have 31 segments, which you've learned in anatomy, 8 cervical, 12 thoracic, 5 lumbar and sacral, and 1 coccygeal. And so the position of the spinal cord, notice in utero, here at 8 weeks, it extends all the way down through the sacral vertebral body level. By 24 weeks, it's pulled up to about S1. And in a newborn, it's maybe here at L3. And this is the position it occupies in adults, L1. Sometimes even it'll end at T12. And so this end of the spinal cord here is called the conus medullaris. And it is very important, as I said, that that's where it ends, for really a lot of different reasons. I'll just give you one. If you want to do a lumbar puncture in a patient, a spinal tap, there's a pocket of cerebral spinal fluid we'll talk about on Thursday that is in this location. And so we might do a lumbar puncture by putting a needle in here at the L4, L5 interspace. So obviously when you do a lumbar puncture, you need to know your anatomy, that you're putting the needle in the right location. But the spinal cord ends way up here, right? So you're not in any danger of pithing the spinal cord, when you do a lumbar puncture. Okay. Notice also that these nerve roots get pulled up further and further during development, and those nerve roots are called the cauda equina. Now, a very small thing, it's really just a naming issue, that the nerve roots C1 through C7 exit above their corresponding vertebrae, but since there isn't a named C8 vertebrae, but there is a named C8 nerve root, then things kind of reverse below that. Okay, so let me just show you this. Here we have the C6 nerve root. It's on top of the C6 vertebrae. C7 is on top of the C7 vertebrae. C8 is on top of T1, but now T1 is going to be on top of the T2 vertebrae. And so, if you're looking at MRI scans or you become a radiologist, you want to be able to, specify which nerve root is involved. I mentioned also, here's the end of the spinal cord here at about L2. And again, notice how far these nerve roots have to travel. Like the L5, S1 nerve roots from the end of the spinal cord have to travel all the way down to exit, the appropriate foramen to supply muscles. So all of these nerve roots here are called the cauda equina. Now finally, just a little clinical aspect. We'll spend a long time talking about this in several different lectures, but it's important you're aware of the terminology. Here's the spinal cord. Okay, one interesting thing about the spinal cord is in the brain, we talked about the cortical neurons are out around the surface, and then the white matter pathways are in the center. Well, in the spinal cord, the neurons are located here in the center. We have the pathways out around peripherally. Okay, but here are the nerve roots. Sensory come in the dorsal part of the spinal cord. The motor exit through the ventral portion. Okay, and so it's very common that patients will have a disc protrusion and that will end up impinging on the nerve roots here. The lay term is a pinch nerve. I have a pinch nerve in my back or in my neck. The medical term for that is called a radiculopathy. Okay, so we'll need to talk about that since it's such a common condition. Now, if there's a disc herniation and it ends up compressing on the spinal cord itself, that looks very different clinically. It's obviously much more serious, and that is called a myelopathy.